However, looking at the histology, it is very clear that with the upper migration of subcondylar bone, the the thickness of cartilage is also very clearly reduced with time. So I guess it is reasonable to speculate the lower part of the repair cartilage may convert to osseous tissue, with osteogenic differentiation. What do you think about this idea?
Thank you, Nori. That's an important question because this was our hypothesis. Our hypothesis was if the bone plate advances, then it's quite. Our hypothesis was that I can speak now. So once the subcondylar bone plate advances, it leads to degeneration. That was our hypothesis, and we were thinking it was a large animal study, like in the individual measurements, like when you have a much advancement, you have also very bad numbers of cartilage repair score, like using the Sellers or the Wakitani score. But this was not the case in the individual animals, so we did not see this correlation. So this was a rabbit model, and a rabbit is not a patient. I still think that there is more to it, so that's why I just tried to play it safe to say we didn't see it in this model, it might be different. I think there's more things to study. I don't think it's an easy answer like we have hoped. But I still think if the subcondylar bone plate advances, it's really something to be a bit worried about. But from a scientific point of view, I cannot tell you, yes, this is the reason in this model. So we need to do more work.
I understand degeneration is not promoted, but what do you think of the promotion of some osteogenic, the osteochondral, pseudo-osteochondral, ossification pathway? What about the change conversion of the deeper area of the repair tissue to the osteogenic, which is not degeneration? It's a process of.
I think you're right. I think that's what's happened. I think we have. It might not be like a growing. It might be a change of the basal layers to convert into bone during this endochondromotomy. That might be the reason.
Dr. James?
Thank you again for really a wonderful lecture. I really enjoyed now listening to the review articles itself. I'd like to follow up. Very nice classification, but there's a little bit about a solution. What do you think of people doing like reinforcement to sort of strengthen the subcondylar bone that way? Do you think there's any future in that sort of more so-called reconstructive kind of treatment?
Yeah, that's an excellent question, and I think that's something to look into. I'm not aware of at least a clinical study who has really addressed that with focus on the subcondylar bone. There are studies about bone, but from the subcondylar bone, it might be a logical thing to do.
Dr. Henning, since we are on this part, you see the earth has various plates, and by drilling into the subcondylar bone, are we disturbing the plates and giving rise to this problem of cyst formation and upward migration and expecting a big disaster to happen, or what do you think it is?
Yeah, that's an important clinical question because we drill through the plate all the time, or we pick through it. I think we have so much evidence that marrow stimulation works for small defects that I think it's still a good technique. But for example, we could always think that we have to do it careful. For example, when we do a microfracture, we might want to avoid that the holes break into each other, or we try to remove the debris. We try to make it as clean, as nice as possible. It's just something to consider. But I think it's good to have a very clean and good technique doing it.
Yeah, I could add something because clinically you could see a difference between different types of scaffold that you are using. If you are using just microfracturing, that is what you could expect, that there will be an in-groove of the bone plate and also this intralesional osteophytes. But for example, if you are using a scaffold in the subchondral bone, a porous scaffold, you very seldom see this big bone ingrowth. So that is something that you need to study more, this type of different types of scaffold that could reduce this bone growth.
I have a question for Professor Pittsburgh. You talked about fascinating injuries in cartilage injuries. What is your opinion about the micro trauma for the cartilage? One, and over the time, what happens like the stress injuries? Is there some study on that? And second part is the deformity. Cartilage subject to a deformed joint. What happens to that? Are there any studies?
Well, regarding microtrauma, you could think about microtrauma like running a marathon. That has not been shown, for example, that people running marathon would have more development of osteoarthritis. But also you remember that there is this possibility of the cartilage if you have a genetic predisposition. Those are the patients that maybe that we should find early on and advise them to choose different types of work, and maybe they should avoid the different types of sports because they could be in danger of developing away in the future. But still, we have very little knowledge about that. And as you saw in this rat model, even though the rats that were genetic predisposed, they could develop OA, but the other ones, even though they were old, they never developed OA, even though they had a cartilage injury. So I think the genetics part is the crucial thing to look for in the future. And we have this possibility with the genetic mapping today, even though that's a sensible part to discuss, but that's important for the future.
Reasons which are asymptomatic. So, in your talk, you said there are few cartilaginous lesions which are asymptomatic. How to diagnose those asymptomatic in the patients without having ACL or PCL? Or patient comes with OPD, how to diagnose that?
Yes, that's an important and difficult question because today we have no exact information about the lesions that are asymptomatic. You have a patient that have no symptoms, you follow that patient and you can see that if the patient has cartilage lesion, there will be subsequent thinning of the cartilage. So those patients, even though they have no symptoms, could have the risk of developing OA. But at the same time, operations are invasive. That could be difficult for the patients also, and also the costs for the community with these operations. I think that will future possibility to detect early on those lesions that are the dangerous ones. Maybe as Henning had talked about the subchondral bone, I think a lot of the secrets of the cartilage is in the subchondral bone, and we are now doing research on neuropeptides. Neuropeptides give signals about where there will be a development of pain. So you could do an objective pain mapping of those lesions. Maybe those lesions are the lesions that we are going to treat in the future. So then maybe in 5 years that we could say that that is a lesion that we could leave, and the other lesion, there is a reaction in the subchondral bone, and we treat that lesion. And then we could, with a PET scan, for example, follow that lesion, how that lesion will be becoming better and better, and we have an objective evaluation of the pain situation.
After certain, just like cardiac checkup, you should go for cartilage checkup.
That could be something for the future as well. Yes.
Yeah, one last question.
Dr. Mandri. You said regarding the cartilage, it's a little unpredictable what it does. In the sense, it's not forming cartilage enough as you expect it to. Is that what it is? Could it be due to the fact that the cartilage can either differentiate into, or the stem cells can either differentiate into cartilage, or it can do what it does in the epiphysis, form bone? So is it likely that some of these mesenchymal cells or stem cells are behaving like epiphyseal cartilage and forming more bone rather than forming cartilage? Would there be a change like that? That's the reason why it's unpredictable.
Yeah, I think that's a good question, because we will discuss it a little more in the next session when we will present ideas about the role of the different cells. I believe that the cells are following their initial mission, and the mesenchymal stem cells, for example, in the bone marrow, they are decided to produce mainly bone. And that means even though they could produce cartilage, it's an unstable cartilage tissue, and they could, and you will see that there is the possibility that this tissue quite easily could calcify or even instead produce bone than cartilage. Maybe you have a comment.
Yeah, I think when you think about it in a very easy way, like your cartilage defect is a bucket, and then the mesenchymal stem cells arise, so the bucket is full of water, and then somehow somebody tells them on the top kind of make cartilage so as maybe to freeze, and on the bottom to become bone, and not to freeze, so you have two layers. But the mechanism how that happens, we don't know much about it. So there are probably some signals coming from the neighboring bone and from the neighboring cartilage who tell the cells, please become a chondrocyte, please become a osteoblast. But how they decide how many of them, we don't really know. And I'm sure that biomechanics also plays a role. So maybe it's a loading thing. Maybe if you have more loading, then more cells decide to become chondrocytes and less osteocytes. But this, on the other side, you could argue, since the advancement is a thing that happens after months or maybe years, this is quite a long time when the patient is already undergoing normal weight bearing. So it's an open question, but it's an interesting debate. Maybe we have more time to chat about that.
Okay. Thank you, Dr.